Hello, my name is Krystal Jones and I am a postbac student at Charles R. Drew University. Today I will be discussing stakeholder views on trauma-informed childhood obesity care. In 2019, 46% of those in 5th grade were overweight or obese compared to the national prevalence of childhood obesity, which is at 20%. This has been growing over the last decade. Certainly now that we are in our 3rd year of COVID, stay-at-home orders and virtual instruction has impacted the obesity among low-income minority children. Children with 4 or more adverse childhood experiences are twice as likely to be obese. Adverse childhood experiences, or ACEs, are traumatic experiences that can include physical, sexual, or verbal abuse, physical or emotional neglect, losing a parent to separation, divorce, or death, experiencing a family member who is diagnosed with a mental illness or who is addicted to a substance, also experiencing a family member who is in prison or a victim of domestic abuse. Trauma-informed care integration can mitigate the effects of trauma and toxic stress on physical well-being. Trauma-informed care is a strengths-based framework grounded in an understanding and responsiveness to the impact of trauma that emphasizes physical, psychological, and emotional safety for both providers and survivors, which creates opportunities for survivors to rebuild a sense of control and empowerment. Now, currently, there is limited research on how to best integrate trauma-informed care into childhood obesity counseling in low-income minority communities. Therefore, the purpose of our study is to develop a consensus among community stakeholders and medical and behavioral experts of best practices for incorporating trauma-informed care into childhood obesity counseling in the primary care setting for low-income minority children. We plan to use a modified Delphi method which incorporates a set of surveys and semi-structured interviews in which stakeholders and experts in the field of trauma-informed care will rate clinical guidelines. Guidelines deriving from organizations such as the American Association of Pediatrics and the National Child Traumatic Stress Network. Participants will rate based on level of importance, necessity, and feasibility of incorporating the practices into low-income minority community clinics. Our first step is to compile a list of current practice recommendations based off of a literature search from which we plan to create the survey for experts to rate. These are the current results on trauma-informed care integration into childhood obesity management. We plan to uphold the current standard of practice for childhood obesity management and want to add in elements of trauma-informed care that would be helpful for low-income minority communities. In other words, we're trying to supplement current childhood obesity management with the trauma-informed care approach. We are still in the preliminary stages of our literature search, but here are the results that we have so far. The overall aim is for providers to understand the importance of helping the patient and their family with an unbiased, culturally sensitive approach. Nutritional recommendations should focus in on the day-to-day progress rather than the number and outcomes related to weight loss, such as inches lost or decline of hemoglobin levels. Although that is the ultimate goal for the provider and the patient, the focus on the step-by-step process is where the trauma-informed approach can be applied. We also want to highlight how emotions and feelings can affect decision-making. The clinician's role is to help guide children and their families identify their emotions and feelings behind the decisions made for what they eat and how they exercise. As previously stated, we are in the preliminary stages of our study. Therefore, we hypothesize that the multidisciplinary panel will come to a consensus of best practices in adapting an evidence-based trauma-informed care program for childhood obesity counseling. We anticipate that there will be a range of recommendations that the stakeholders consider as both necessary and feasible within primary care practice. The results of this study will inform the current integration of trauma-informed care practices into 2 community primary care clinics in South Los Angeles. Lastly, I'd like to show appreciation for the provided support. If there are any questions or if you'd like to hear about the next steps in our research, please feel free to email me at krystaljones@cdrew.edu. Thank you for listening.